Von LINDAU syndrome is an hereditary disorder. Look at this picture shows that multiple organs affected by tumors, renal, neural, pancreas. Look at this. Then CT scan findings. Look at this renal tumors. Then MRI findings. Detail going on. Introduction. Van HIPPEL syndrome (BHL) is a rare inherited disorder characterized by the formation of tumors and cysts in different parts of the body. These tumors may be benign or malignant and commonly affect the brain, spinal cord, kidneys, pancreas, and eyes. The condition results from mutations in the VHL gene, which plays a critical role in regulating cell growth. A definition: Von HIPPEL syndrome is a hereditary multi-system disorder that predisposes individuals to various benign and malignant tumors, particularly hemangioblastomas, renal cell carcinoma, and pheochromocytomas. Etymology: Van HIPPEL syndrome is named after German ophthalmologist Eugen van Hippel and Swedish pathologist Arvid Lindau, who independently described its key features in the early 20th century. Van Hippel identified retinal hemangioblastomas, while Lindau later linked these tumors to central nervous system and other organs involvement. Types: VHL is classified into two major types. Type 1, characterized by a lower risk of pheochromocytomas, but an increased risk of other tumors. 2. Type 2 further divided into Type 2A, increased risk of pheochromocytomas and hemangioblastomas, but a lower risk of renal cell carcinoma. Type 2B, increased risk of pheochromocytomas and renal cell carcinoma. Type 2C, presence of pheochromocytomas only, without other tumors. Causes: VHL syndrome is caused by mutations in the VHL gene located on chromosome 3p25 to 26. This gene normally suppresses tumor formation by regulating hypoxia inducible factors HIFS. Mutations leads to unregulated cell growth, resulting in tumor development. Risk factors: 1. Genetic inheritance, autosomal dominant pattern. 2. Family history of VHL. 3. Germinal mutations in the VHL gene. Complications: 1. Vision loss due to retinal hemangioblastomas. 2. Neurological defects due to brain and spinal cord tumors. 3. Hypertension due to pheochromocytomas. 4. Renal failure from kidney tumors. 5. Metastatic renal cell carcinoma, which can be life-threatening. Pathophysiology: the mutation in the VHL gene leads to the loss of function of the VHL protein, a critical regulator of HIFs. This dysregulation results in abnormal angiogenesis, uncontrolled cell proliferation, and tumor formation. The increased vascularization of tumors leads to complications such as hemorrhages and cysts formation in affected organs. Step-by-step pathophysiology of Van Hippel-Lindau syndrome. 1. Genetic mutation. VHL syndrome is caused by mutation in the VHL tumor suppressor gene located on chromosome 3p25. This gene encodes the VHL protein, which plays a key role in cellular oxygen sensing and protein degradation. 2. Loss of VHL protein function. Mutation leads to either a complete loss or dysfunctional PVHL, impairing its role in targeting hypoxia. Inducible factors HIF for degradation. 3. Accumulation of HIF, hypoxia inducible factors. In normal condition, PVHL binds to HIF, a subunits, and promotes their degradation via the ubiquitin proteinosome pathway. Without functional VHL protein, HIF A is not degraded and accumulates in cells. Even in normoxic conditions. For over expression of hypoxia responsive gene. Stabilized HIF, it translates to the nucleus and activities genes involved in angiogenesis, cell proliferation, and erythropoiesis. This leads to excessive blood vessel formation, abnormal cell growth, and increased red blood cell production. 5. Tumor formation and multi-system involvement. Dysregulated angiogenesis and proliferation results in highly visualized tumors, commonly including A. Hemangioblastomas, brain, retina, spinal cord. B. Renal cell carcinoma. C. Pheochromocytomas in adrenal medulla. D. Pancreatic neuroendocrine tumors. E. Endolymphatic sac tumor, inner ear causing hearing loss. 6. Progressive diagnosis manifestation. Tumor growth lead to neurological, visual, endocrine, and systemic complications depending on location and size. Recurrent tumor development and metastasis, particularly in renal cell carcinoma, contribute to morbidity and mortality. Signs and symptoms. 1. Neurological symptoms: headache, dizziness, ataxia, weakness. 2. Ophthalmologic symptoms: vision disturbances, retinal detachment. 3. Cardiovascular symptoms: hypertension due to pheochromocytomas. 4. Renal symptoms: hematuria, flank pain due to renal tumors. 5. Pancreatic symptoms: abdominal pain, pancreatic cysts. Diagnosis: 1. Genetic testing for VHL gene mutations. 2. Imaging studies: A. MRI, CT scan of the brain and spine for hemangioblastomas. B. Abdominal CT MRI for kidney, pancreas, and adrenal gland tumors. C. Ophthalmologic examination for retinal tumors. 3. Biochemical tests. A. Plasma metanephrine levels for pheochromocytomas. B. Urinary catecholamines. Nursing diagnosis. 1. Risk for ineffective cerebral tissue perfusion related to brain hemangioblastomas. 2. Risk for impaired vision related to retinal hemangioblastomas. 3. Acute pain related to tumor growth and cyst formation. 4. Anxiety related to the diagnosis of genetic disorder. 5. Risk for ineffective renal perfusion related to renal cell carcinoma. Medical management. 1. Surgical resection of tumors when feasible. 2. Radiotherapy for inoperable tumors. 3. Targeted therapy with tyrosine kinase inhibitors for RCC. 4. Blood pressure management for pheochromocytomas. Nursing management. 1. Monitor neurological status for signs of increased intracranial pressure. 2. Assess for visual disturbances and provide necessary referrals. 3. Educate patients about genetic counseling and family screening. 4. Provide emotional support and psychosocial interventions. 5. Monitor for signs of hypertension and administer antihypertensive medications as prescribed. Treatment options. 1. Surgical removal, hemangioblastomas, renal tumors, adrenal tumors. 2. Laser therapy or cryotherapy for retinal hemangioblastomas. 3. Radiotherapy for inoperable CNS hemangioblastomas. 4. Targeted therapy, tyrosine kinase inhibitors for RCC. 5. Active surveillance, regular monitoring for tumor progression. Psychosocial medicine. 1. Genetic counseling, educate patients and families on inheritance risk. 2. Support groups, encourage joining BHL patient communities. 3. Coping strategies, psychological support for dealing with chronic illness. 4. Patient education. Provide information on symptoms and early intervention. 5. Lifestyle modification. Stress reduction, diet and regular medical checkups. Prevention. Since VHL is a genetic disorder, prevention focus on early detection and risk reduction. 1. Regular screening for at-risk individuals. 2. Family genetic testing to identify carriers. 3. Avoiding environmental risk factors that may exacerbate tumor development. 4. Lifestyle modifications to support overall health. In conclusion, von Hippel-Lindau syndrome is a complex genetic disorder requiring lifelong monitoring and multidisciplinary care. Early detection, targeted interventions, and genetic counseling are crucial for managing the disease and improving patient outcomes. Ongoing research into gene therapy and novel treatments offers hope for better management strategies in the future. Thank you. Have a nice day.